Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.
Welcome to The Health Advocates, a podcast that breaks down major health news of the week to help you make sense of it all. I'm Steven Newmark, Chief Policy Officer at the Global Healthy Living Foundation.
And I'm Zoe Rothblatt, Director of Community Outreach at GHLF.
Our goal is to help you understand what's happening in the healthcare world to help you make informed decisions to live your best life.
And today, for our last episode of the year, we're going to take a look back at 2024 and what's ahead for 2025 when it comes to health policy and advocacy.
And we'll start off by thanking our listeners. We're so grateful to all of you for tuning in.
Yes, thank you, listeners. I really can't believe we've arrived at our last episode for 2024.
Well, let's start by talking about some of the legislative victories that we've had in 2024. These are victories that are really for all patients, but we've been involved in these efforts, and we, again, thank each and every one of you for all that you do on behalf of patients.
Yeah, thank you so much to our community. Shout out to our 50-state network. Without you, this wouldn't be possible. We talk all the time about how resonating a story is, and just hearing firsthand testimony from advocates really does make a difference. So let's go state by state, I guess, for our successes for the year.
Yeah. Well, it's not all 50 states, but we'll go through some of the high-level stuff. So Oregon and Vermont became the 20th and 21st states, and as well as Puerto Rico, to pass laws banning copay accumulator adjusters from passing on financial burdens onto patients, while the federal Help Copays Act continues to gain support in both the House and Senate.
Yeah, it's exciting to see the Help Copays Act gain support. And of course, we always talk about it's almost a little backwards that the states are passing laws before federally, but it does help make a case when we go to federal legislators to say, states are passing these bills. This is what's happening. It helps us gain momentum. So great to see Oregon, Vermont, and Puerto Rico doing this.
Absolutely. And a special thanks to our GHLF members who have been active in those states, working and advocating to their elected officials to make this a reality.
So what's new for step therapy this year?
Well, Illinois, Vermont, and Wyoming joined 25 other states in passing protections regarding exemptions and other step therapy protocols, which means that over half of the country now has these protections in place. On the federal side, the Safe Step Act now has over half of the current U.S. House of Representatives signed on as a co-sponsor, meaning it is closer to passing than ever before.
Yeah, it's exciting to see that over half the states have step therapy protections. These issues also span across diseases, so it impacts a large portion of patients. I know we've been doing a really big push at the federal level for the Safe Step Act and feel really hopeful about it. It's also thinking about that compared to Help Copays Act that we just talked about. It's step therapy is a little bit ahead in the process. So I think that if we could see that pass, it would bring a lot of hope too for Help Copays Act.
Absolutely.
Turning to another issue, non-medical switching. This is when an insurance plan, as it exactly written, non-medically switches a patient. So in the middle of the plan year, they might say, hey, we're not covering your drug. You have to take this one instead. So in Iowa, we saw a big win with the passage of non-medical switching. Iowa also, along with a few other states like Colorado, Connecticut, Florida, and Pennsylvania, passed legislation mandating coverage for biomarker testing, which we hope that this reduced times it takes patients to find the right medication.
Yeah, absolutely. This year was also a major focus for our advocacy team was on state prescription drug advisory boards, or PDABs as we've called them, and the upper payment limits, or UPLs. Gosh, so many acronyms. Anyway, that these PDABs might set for commonly used medications in their states. At GHLF, we were a regular presence at meetings in Colorado, Oregon, and Maryland.
Yeah, this was a great opportunity for patients to get involved in a new advocacy issue. We're seeing them pop up around the states, so it'll definitely be a priority in 2025. And, we were also successful in opposing authorizations on PDABs with upper payment limit authority in Rhode Island and Virginia this year. It's kind of a mouthful, but, we have an episode on PDABs if anyone wants to go back and take a listen. But ultimately, our goal is always just how patients have access to care that is affordable.
Exactly. Very, very well said. With that, we couldn't do this without our advocates. So again, a big thank you. It's, as you said earlier, Zoe, it's your stories and testimony that makes these legislative successes possible.
And just to shout out our advocates a little bit more, I pulled some numbers from our advocacy over the years. So we did over 750 calls to legislators and sent over 1,000 emails. Thank you, advocates. At the state level, we had 75 meetings or testimony and 35 at the federal level. And this is including with our coalition partners. So just like shout out to our coalition partners like Obesity Action Coalition, the Digestive Disease National Coalition. We've had a lot of great times, just connecting with the community to advocate this year.
Yeah, that's what we do. But unfortunately, there's no time to rest. I mean, let's rest a little bit over the holidays. But 2025 is going to be a doozy, to say the least, in the world of patient advocacy. But because of you, we'll be able to keep fighting the fight. So let's talk about what we're looking ahead to 2025. Let's start with the state level, Zoe.
So yeah, at the state, copay accumulators will continue to be, major concern. We see that there might be potential movement in Nebraska, New Jersey, Tennessee, Texas, Utah, and Wisconsin. So, listeners, if you live in those states, email us advocacy@ghlf.org. And if you want to get involved in any of these issues that we're talking about.
Absolutely. And another state is New York, where our primary focus will be the Share the Savings initiative, which is aimed at reducing the financial burdens on patients.
And vaccines are expected to be a critical focus at state and federal level. We actually just launched a vaccine advocacy training program. We'll drop the link in the show notes, but we anticipate that to be a really big push next year, just to promote safe and effective vaccines and ensuring that all have access to them.
Yes, exactly. And that access is not compromised. We'll also be a consistent voice again in 2025 at Prescription Drug Affordability Boards, as even more states seek to address rising drug prices. And we want to make sure that the patient voice is heard as these boards convene.
So turning to the federal level, what's on the agenda for 2025?
Oh dear. Well, we have a new House, a new Senate, and a new administration. So we'll talk a little bit about that in a moment, but we'll start with the legislation, the Safe Step Act. It's so close. We mentioned it earlier. It's at the point where more than half of the members of the House are literally co-sponsors of the legislation. So it's at that tipping point. It's beyond the tipping point. So we hope that 2025 will be the year that we bring successful conclusion on this legislation that we've been working for. I think it's been 6 or 7 years since its first introduction. Advocacy can be slow, but when you keep at it, you can make progress.
And, just a note on the keep at it, the Safe Step Act has co-sponsors remain year over year. They sign back onto it and we get more.
Right, exactly.
So that's also really encouraging to see that support from legislators continue each year.
It continues to grow. Exactly. And earlier we mentioned the Help Copays Act, which is also gaining steam. It's a few years behind the Safe Step Act on the advocacy timeline, but obviously we're going to push as hard as we can to make even more progress in 2025. And yeah, I'll repeat what I just said. Advocacy can be slow, but if we keep at it, we will get the reforms we are seeking.
And other important issues that we'll be focused on are another acronym here, TROA, the Treat and Reduce Obesity Act, and also Improving Seniors' Timely Access to Care Act. So we're looking forward to continuing to support this legislation, also knowing that there's a new administration that may bring about some uncertainty.
Yeah, that's to say the least. So we're going into the Trump 2 administration starting January 20th, and the House policy landscape is expected to shift significantly. We anticipate these changes could lead to confusion for patients, providers. We've spoken in the past about RFK Jr., who has been tapped to head HHS. His confirmation is far from a certainty, but if he does go through, he will wield both enormous power, but also an enormous mouthpiece in which to promulgate some of his thoughts on public health, which don't always align, shall we say, with actual folks who are public health experts and have actually worked in the public health sphere for many decades. So there are other staff changes coming as well. So let's talk about some of the others before going back to RFK Jr.
Sure. So President Trump has nominated Dr. Oz to run CMS, the Centers for Medicare and Medicaid Services.
Yeah, Dr. Oz, he's a TV doctor, but he's also a real life doctor, I suppose.
Yeah, he's a trained cardiologist, isn't he?
Yes.
Yeah. I remember watching him on Oprah back in the day.
Between him and Dr. Phil, she loves her doctors, I guess. He is a cardiologist, and I know he ran for Senate in Pennsylvania 2 years ago and lost.
That's right, yeah.
I don't know if he gave up his position at Columbia to do that, but regardless, he maintained his position even while he was on television, and I think he worked roughly 1 day a week at Columbia Medical University Hospital. His focus on wellness, he may advocate for policies promoting preventive care and more holistic holistic approaches to chronic disease management. It's uncertain what that might look like at a place like CMS. Centers for Medicare and Medicaid Services, as the name implies, really oversees and runs Medicare and Medicaid, which are essentially our public insurance options. So it's unclear what kind of a role or power he might have in influencing Medicare. Medicaid is, of course, is run by the states.
Well, speaking of that, he's previously advocated for the privatization of Medicare, getting rid of traditional Medicare and moving everyone to under Medicare Advantage plan. And I saw that Democratic senators are, seeking clarity on how he's thinking about that now and wrote a letter to Dr. Oz. So it'll be interesting to see how that plays out.
To say the least. It's interesting because the groundswell of public opinion as we record this in December of 2024, if anything, seems to be moving, if ever so slightly, but at least ever so much in the favor of more public health insurance versus private health insurance. So I don't know how popular that would be to actually try to expand Medicare Advantage to the detriment of Medicare proper.
Yeah, I feel like we all know something needs to happen with our health insurance system. It isn't working so well the way it is, but it's really hard to make these changes and a huge overhaul. And we learn in all these health policy classes, none of these changes are perfect. They all have risks and downsides. So it's do you stay with the devil you know or try the devil you don't know?
Yeah, no, absolutely. Absolutely. It's a funky system we have here in the United States. There's a renewed focus, if you will. We didn't talk about it, and I don't think we need to take a deeper dive. But of course, the CEO of United Healthcare was murdered recently, and they've actually captured his alleged assailant. And it is sort of shining a spotlight on the health insurance industry and some of the disturbing practices in which they engage. And I don't think we're going to take a deep dive other than to sort of bounce off what you just said, Zoe. Healthcare is complicated, and ultimately we have the system we have. It's not so simple to just blow it up. The comparison that I've heard that I'm going to copy from here is if you were to dig up the streets of major cities like New York, or even just dig up what's going on underneath the ground, our infrastructure, our telecommunication system, it's like duct taped together basically down there. It's like a total mess. If you were to build an infrastructure from scratch, that's not what you would do. You would start at the basic level and come up with something that's much more useful. That's kind of where we are with healthcare. During World War II, there were wage controls in the United States, and health benefits were seen as a way of attracting talent to businesses. And in the 1950s, labor unions grew in power, and part of what they sought for their members was greater health benefits, and the industry exploded. Whereas other countries, most notably in the UK, their citizens were actually being literally bombed during World War II. And as a result, without much opposition, they immediately said, well, if our people are going to get bombed, we're going to take care of them. And that's when the UK moved to a nationalized system of healthcare, and it forms the basics of a lot of Western healthcare systems. But for us to go purely into that is difficult. Now, that being said, we've moved in that direction. We created Medicare and Medicaid in the 1960s, so we've moved a little closer to a public health option. The Affordable Care Act got us a little closer in mandating health coverage for all U.S. citizens, and we moved in that direction, but the idea of blowing it all up and starting from scratch, that's, shall we say, unrealistic.
Even take the ACA, for example, Affordable Care Act, that had been trying to get passed since Nixon? It'd been a really long time. And then
Right, depending on how you want to date it. Yeah, absolutely.
and then we got that through a backdoor passage, and it's not perfect, but that was a big change.
Right. As I said, it moved us a little closer. And to repeat what we said in the earlier segment, advocacy takes time, and some things take longer than others.
A good title for the episode, Advocacy Takes Time.
Yeah, it's a slow slog. And often it's not perfect. But yeah, that moved us in more of a socialized medicine. I mean, I see comments online, particularly in the wake of this horrific murder, things like, the insurance industry stinks. Everyone should have free healthcare. It should be like the UK. And I just want to say on a one-on-one basis, it's not quite that simple in the sense that healthcare is expensive. First and foremost, it costs a lot of money to run and operate a hospital, number one. Number two, the people in healthcare are very, very well trained for what they do. They get a ton of schooling from nurses to technicians, and of course, doctors. The amount of schooling they get is extensive, and they need to be compensated as a result. As for various therapies that individuals take and medical devices and drugs, those are the amount of research that needs to be done in order to develop a drug is extensive and literally costs billions and billions of dollars. And oftentimes the path that scientists take is one of failure. Even when it's one of success in discovering how to use a medication to address a drug, you then have to go through clinical trials to ensure its safety as well as its efficacy, of course. And that is another cost that's added on top. I wish everything was free, right? I wish cars were free. I wish my TV was free. I wish I didn't have to pay rent. But healthcare, it's hard to get it to be free without giving something up. Someone's going to have to pay at some point.
But we can all agree there's like an unfair burden on patients, especially chronic disease patients, which is why we advocate for the policies that we do.
Definitely. So, I mean, and I would say, and I've said this on this program, I think the issue is ultimately the way it works is whether it's private insurance or public insurance, those who are healthier should subsidize those who are less healthy. And what I mean by that is if you have a chronic disease, let's just take chronic illness. If you take chronic illness and have to take expensive medications, there are two ways to look at that. You could say, too bad, so sad. You got to take your you ended up with that. I'm healthy. Why should I have to pay for that guy? Or another way to look at it, and the way I prefer to look at it is if I am lucky enough to have been born and go through the majority of my life without the need for expensive medications or surgeries, and I'm healthy, I would gladly pay a little bit more into the healthcare system, whether it's public or private, so that other individuals who already were born with a strike against them don't get that additional strike of having to try and struggle to pay for products that could actually make their lives better. I want to live in a society where we're all living as healthy lives as possible.
For sure.
And by the way, I understand that's very socialistic to think like that, but anyway.
Yeah, but even if you're like thinking selfishly, like you may be healthy now, but this kind of dark, you're not always going to be healthy. Like once upon a time, I didn't have a diagnosis and then I did, you know?
That's true. I mean, look, I have car insurance and I hope to never have to use it. I have flood or fire insurance, whatever. I hope to never have to use those things, but I get them out of a sense of selfishness in a way, right?
Yeah. Well, I guess to round out that discussion, we'll do what we always do, educate patients, bring together community, and share patient stories to advocate for better policies.
Definitely. And I'll just say, because I know we didn't do a deep dive on like the top of the food chain over there, no pun intended, or maybe a pun intended, I'm not sure. RFK Jr. Well, in the coming weeks, this is our last show before the new year. In the coming weeks, we'll see how much traction he's getting. If it looks like he's going to pass muster, we'll certainly start to talk about it a little bit more as to what we're doing. Before we close, let's talk about what you, our patients, can do in 2025.
Well, number one, join our 50-state network. We'll help you tell your story, figure out what issues you want to advocate on. We'll put a link in the show notes, of course.
Definitely. Stay informed through our newsletters, webinars, and of course our podcasts. And then, share your story to inspire change and highlight real patient experiences. Email us at advocacy@ghlf.org to get involved.
And as we head into 2025, Happy New Year, everyone.
Happy New Year.
I feel really optimistic about the impact that we can make together.
Well, Zoe, on a personal level, I just want to say it's been a phenomenal, fun time in 2024 doing this podcast with you. And I wish you and your family all the best as you head into the holiday season, and a very, very happy new year.
Thank you. You too. And yeah, I'm excited to see what's to come for us in 2025. We got some pretty cool statistics from our Spotify Wrapped and saw growth in listeners. So Steven, it'll be great to continue doing this with you in the new year and see our community grow.
Absolutely. Before we go, we want to encourage everyone to check out all of our podcasts at ghlf.org/listen.
Well, everyone, thanks for listening to The Health Advocates, a podcast that breaks down major health news of the week to help you make sense of it all. If you like this episode, give us a rating, write a review, and definitely hit that subscribe button. I'm Zoe Rothblatt.
I'm Steven Newmark. We'll see you next time.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.